First. All right. Happy June and happy June 16th today. I welcome to each and everyone. In terms of the review from last night, somebody requested, can I do a test taking strategy? I just would like to thank all those students that have tagged their friends, their best friends at PMHNP school, taking up PMHNP, or if you're actively practicing, then welcome to another session. Please like, share, subscribe for those who are in Hawaii, Pacific time, Mountain time, Central time, and Eastern time. Thank you so much for choosing us as your board preparation. Okay. See here. We're just waiting for a few more minutes until I go over some pertinent concepts. All right. Henry, Casper, Manuel join, and also Karen. So I need to move my camera around and splice there. Split. Is my camera okay, guys? You can all see me. Once again, welcome. Karen joined from Instagram. Hi, Dr. Karen Sutherland from New York. Once again, for those who are tuning in to our live, once again, please like, share, subscribe, and tag your PMHNP friends who needs to hear this program. And don't forget our Rise with Pass. This is our official workbook for those who are testing for the exam. Once again, available to our website. So it has a lot of like mnemonics. We're gonna go over some of it, and you can write some down. You can write some notes here too, which I like. So very effective, and it has board notes review questions. Very good. So once again, um, we welcome all the viewers out here, and welcome to PASS. Another product that we have is the PMHNP Masterfield Clinical Concepts. So it has all the mnemonics. What else? Some study notes covering the different 5 domains, and I like how concise is it, and very easy to read. So please make sure to like, subscribe, and also join our live review upcoming in the next few sessions. Okay. Welcome, Everett, Kevin. A lot of people are following us also on TikTok, Instagram, LinkedIn, Facebook, and of course, our community. Thank you for the trust. So we've been around since 2015 and running different programs, NCLEX, FNP, PsychNP, AGNP, and also our signature PMHNP one-day prep review. So that's your last minute preparation. Okay. Please type in on the chat box where you guys are from so I can greet you, and what time zone do you guys belong to. Some are from the Philippines too. I was surprised last week somebody from the Philippines typed in their name, so would like to get to know you guys as we go along. Once again, if you have a PMHNP friends, PMHNP in practice, PMHNP that needs mentoring, PMHNP that needs to refresh their content areas, or somebody who need to manage their test anxiety, then probably this video is for you. And this live is brought to you by Pass Review Center. And we're gonna give you some mnemonics, test taking strategies, and also how to manage keywords, options, and how to break down the options in your exam. So Since 2015, we've been helping out students from East Coast, West Coast, and also in Hawaii. We have some students in Hawaii too that have took our exam. The farthest territory that we have covered is Guam. So we have a passer from Guam also. And uh, and a lot of Philippine students are coming into the distribution. So let's start. I think everybody's ready. Thank you once again. If you have a question, type in your questions or inquiry into the chat box. So welcome to a very exciting day. Your test taking strategies. So from Hawaii, Pacific Standard Time, Mountain Time, Central Time, and Eastern Time, we cover all the areas. So if you're listening in, or if you have a friend that is needing to refresh their contents once again, or to get to know what is test taking strategies and what we offer in our company, then this will be the best time for you guys to check us out. So our motto for pass is pass the boards and practice confidently. So what do we mean by that? We don't just help you pass the exam, but we also want you to become an entry level safe clinician and at the same time creating an impact to our community. As we know that nurses and nurse practitioner are the number one trusted profession, and we want to make sure that you guys are ready to pass the boards. So if you guys are following us in Instagram, YouTube, LinkedIn, Instagram, and TikTok, and Facebook, and also please follow, like, and subscribe, and even tag your friends. Just tell them that we exist and we're here to help you out. And if you're not part of our mailing list, you get free classes, free CEUs, and also join us for raffles and everything, and free offers for the book, especially 10%. Don't forget the code thank you 10 to get 10% of the PMHNP clinical concepts and PMHNP mastery. And I also would like to promote the class happening on June 27, 2026, Saturday, 8 a.m. to 2 p.m. Pacific time. And I will be joined by Professor Ladilu, who is a Psych NP Board certified. So both of us will run the high yield review, focus prep, and we want to walk you through different content areas that you need to test with clarity and manage your anxiety. And don't forget to use the code WELCOME10 for 10% discount. Everybody loves 10% discount, so that's very important for you guys to book as soon as possible. Hi, Tamara from San Diego, California. I love San Diego. I was just there last week. I love Phil's barbecue. And then that's another study collection that I want you guys to remember is the psychopharmacology. Currently, we sold out of our physical copy, officially sent out our physical book, but ebook is available for purchase, and the physical book will arrive probably later, will be next week, but you guys can pre-order already our PMHNP Mastery Psychopharmacology, 400 pages of high yield content areas. So scan the QR code and use past 10 to avail our 10% discount. If you're getting them from Etsy, I think it's thank you 10. So make sure get those bundles. So it comes with this one and this book too, and then your PMHNP Mastery. So please do not forget to tag your PMHNP friends that are listening in and will be testing or they're actively practicing. This is a good resource book that you guys can buy. And it's available for you. We deliver. So the first task taking strategy that we're going to tell you is safety first. As we know, safety is a priority for our patients, and we have the mnemonics SAFE. So when we talk about caring for patients who are struggling with their mental health, our first priority is to assess if they're suicidal or homicidal. And how will you know if the patient is suicidal or homicidal? So there are certain cues and also behaviors that we could assess. If they're giving away their belongings, like probably they will tell you, okay, this is my favorite phone, I'm giving it away to you, and this is my favorite guitar, I'm giving it away to you. and I feel like there's no reason or no meaning in my life right now. Please take care of my things, or take care of my cell phone, or take care of my guitar, or take care of my book. And that's probably you have to ask them like close-ended questions. And then remember, they could be active or passive. Suicidal thoughts, active means they're what? They have a plan and they're gonna do it. While passive suicidal thoughts means they have verbalization that they want to die, but they don't have any active plans. So think about letter S, suicide, homicide risk, and then assess if they have access to weapons. That's very important. And then letter A stands for abuse or neglect risk. As we know, we could not ignore abuse. It can be an elderly. It could be what. It could be domestic violence, or it could also be child abuse. We always need to include the Child Protective Services, or call the CPS, investigate further. The next letter is letter F. Anybody who is at risk for falling, especially if they're on polypharmacy, they're on different medications, right? That causes the blood pressure to drop. And that is what you call orthostatic hypotension. So we're looking at falling, overdosing, and toxicity as at risk for as a high risk for falling, high risk for overdose, and high risk for toxicity is a priority. Next is letter E, emergency or medical danger. Somebody who is experiencing symptoms of stroke, experiencing symptom of hypertensive crisis, somebody who has chest pain that is unrelieved by medications. So we always need to prioritize them and look at your keywords. Priority, what is the first action, what is the best action, what is most appropriate. And those are things that we need to consider for. Now, this is a past formula. If someone is unsafe, stabilize safety before therapy, teaching, or long term planning. So let's apply that in the next question. Next slide, please. Thank you. So you have a 32-year-old patient with major depressive disorder. As we know, per DSM-5, the criteria for major depressive disorder is at least 2 blue weeks, and you have 5 out of 9 based from the DSM-5 characteristics. So 5 out of 9, 2 blue weeks, and they're presenting for a follow-up appointment. During the visit, the patient states, "I have stopped going to work. I barely eat, and my family will be better off without me." So the patient also reports poor sleep and low energy. Which action should the PMHNP or psychiatric mental health nurse practitioner takes first? So it's already bold and it's highlighted there that you need to make sure you prioritize what is important for your patient. Letter A, do we prioritize reviewing sleep hygiene strategies? Letter B, do we increase the antidepressant dose? Letter C, do we conduct a suicide risk assessment? Or letter D, do we encourage participation in cognitive behavioral therapy? So remember, you have a minute per question in a multiple choice question. Take out two options that are potential distractors, choose between two, and choose the best answer. So let's look at the audience poll answer. Okay, type in your answer into the chat box. Janet White said C. Jan Guzman said letter C. What else? Everybody that are participating to our live, please type in your answer into the chat box. John Guzman is from Baltimore, Maryland, right? Buhay. Yes. And then Rosaline Quarty said letter C. So let's look at letter A, reviewing sleep hygiene strategies. Do you think it's a priority, or we can do that later? Letter B, increasing the antidepressant dose is what? Very invasive. So what does it mean? We always start from simple intervention before we do a complex intervention. So always do non-pharmacological before pharmacological approach unless it's emergency situations. Okay? So letter B, we need to cut them off. Letter C, conduct a suicide risk assessment. A lot of you answered letter C. And I definitely agree with your answer that the answer is letter C. So A, B, and D are all out of the priority. Our priority for a patient is to make sure we conduct a suicide risk assessment, right? I told you that a while ago. It could be a passive suicidal ideation or an active suicidal ideation. So the patient is expressing possible suicidal ideation. My family will be better off without me. And that's like a subjective complaint for your patient that warns us, hey, there's something wrong with the patient. And this verbalization entails that do they have a plan and do they have access to weapons? And what do we need to do is to make sure that um, we discuss the medications therapy or lifestyle interventions next. But our priority is to talk about safe. Hi, Miss Alice Benjamin, thank you so much for tuning in. Make sure we follow the SAFE principle. Letter S stands for suicide risk, and then also assess immediately. As we go back to the previous slide a while ago, can we emphasize again the mnemonics? Don't forget SAFE. S stands for suicide or homicide risk. A is abuse or neglect risk. F is falling, overdose, and toxicity. And letter E stands for emergency and medical danger. Thank you. Don't forget safety comes first. Yay! We have a lot of great PMHNP students that are typing in their answers. So if you're tuning in, please make sure to tag a friend, like, subscribe, and also send this to somebody who is needing help with their task taking skills. My task taking strategy number two is rule out medical issues first or medical first. So we have the mnemonic mimic. Okay, so M stands for medical conditions. And as I've told you, if the patient is suffering some delirium or some episodes of hypertensive crisis, we need to rule it out. If they have hypertension, if they have anxiety, and now it's not managed, they can lead into stroke or cerebrovascular accident or even myocardial infarction. Or if they have intoxication, that's very important. Always assess for your alcohol abuse or screening tool like your cage or even your SIWA, right? And then your letter M stands for medication side effects. Very important for our board exam and for our clinical practice. We need to look at medication side effects for our patient. Like what are the most common ones for SSRIs are usually your nausea, vomiting, diarrhea, and also your erectile dysfunction, especially if they're on paroxetine or Paxil. And then illicit substances. Remember, your use of your illicit substance can either cause the medication to be more toxic than usual or less effective. So we're looking at inducers and inhibitors for that. Okay. And then next, letter C, cognitive disorders. And that's very much important when we cater to our patients. We need to rule out medical conditions. Are they on any substances? We need to do urine toxicology before treating the patient or adjusting any medication. So the golden rule is any new onset of psychosis in older adult. Think about letter D, delirium. Think about another letter D, dementia. Think about letter I, infection, or even substances and medication. So remember, order a urine toxicology before doing anything else because if it's a new onset psychosis for an elderly, usually it can lead to either dehydration, UTI, delirium, or it could be due to illegal or illicit substances. Let's go to the question. Next slide, please. Thank you. A 72-year-old patient with no psychiatric history is brought to the ED by family members. Over the past 2 days, the patient has become increasingly confused, is seeing people in the room, and has been awake most of the night. Family reports that the patient was functioning independently last week. What is the psychiatric mental health nurse practitioner most appropriate initial action? There you go again. The question is asking what is the PMHNP's most appropriate initial action? Is it letter A, diagnose brief psychotic disorder? Do we do that right away? Letter B, assess for underlying medical causes of the symptoms. Letter C, initiate an antipsychotic medication. Remember, start with least invasive before more invasive, right? Start with simple interventions before you go with complex interventions. Or letter D, refer the patient for outpatient psychotherapy. Type in your answers into the chat box. All right, we are giving you enough time to type in your answer into the chat box. Thank you. Your participation is highly encouraged. Please tag your friends who are needing to pass their board exam. Either you're struggling to pass your board exam or you are new to the process of taking an exam. Welcome. Or if you have passed the exam but you want a refresh of your content areas, we're here for you. All right. So let's look at letter A, diagnosing brief psychotic disorder. Did anybody answer that? Majority of you answered letter B and letter C. Okay. Remember, always follow your nursing process. So, do we diagnose? Do we assess? Do we initiate? Do we refer? Remember, as a psych mental health nurse practitioner, we always carry the responsibility of doing something before we refer it, right? Always remember, do not pass the responsibility because it's within your scope of practice. So let's reveal the answer. A lot of you have answered letter B, and great job. Always follow your nursing process ADPI, assess before you diagnose, before you plan, before you implement, before you evaluate, and then go back again to assessment. So remember, assess, diagnose, plan, implement, and evaluate. We always need to make sure to assess the underlying medical causes of the symptoms. If it's acute onset, 2 days, then that's abrupt. It means it's acute, means it's more delirium. If it's more chronic, then it's more dementia. So you want to look at the time frame. You want to look at fluctuating confusion and also visual hallucination. Some patients with Lewy body dementia could have visual hallucination as the hallmark of it. Advanced age, as we know, elderly patients could have episodes of psychosis, so we need to also rule that out, and no prior psychiatric history. These findings strongly suggest delirium until proven otherwise. So, what are the main causes of your delirium, right? There could be intoxication with substances, dehydration, pneumonia, use of corticosteroids, use of your opiates. So, there's a lot of factors that could cause delirium. So, we need to rule that out, do your root cause analysis before treating the patient. Always do your assessment. So that's your test taking strategy question number 2. Let's go to the next step. I know all of you are doing a great job. Okay, prioritize the acute over chronic. So our mnemonics is now. So what do you mean by now? N stands for new symptoms. So if this is a new report of the patient, it's really important to pay attention to it. And letter O stands for overwhelming risk. Okay. So what could be the most important thing that we need to remember if they have access to weapons, what else they are telling you they're gonna hurt themselves or overdose on their medication. They will take their fentanyl and their Xanax together, so that's like risk factors, and they have addictive histories and also worsening condition. So remember, if their vital signs are fluctuating, if their cow CWA are not improving, right, or if they have worsening symptoms based from their screening tool. So multiple problems are listed for your patient. So the board rule is always address the most urgent, unstable, and life-threatening issues first. So who are those? The vulnerable population, if they're pregnant, if they're elderly, if they're vulnerable populations like the children, what else? Somebody who is telling you that they have a gun in their home, they can shoot themselves. So you need to make sure you have a duty to warn if they tell you they're gonna shoot their friend tonight at 7 p.m. after their shift at McDonald's. Then we have a tower soft law that we need to remember. Okay, let's look at the question and how do we apply now. So a patient with bipolar 1 disorder presents with stable hypertension managed by a primary care provider. They have a chronic insomnia and they have a new onset of severe agitation and pressured speech. They also have a mild weight again from mild weight gain from medication. So what should the PMHNP address first? Once again, very important to look at the diagnosis of the patient, bipolar 1 disorder. What else? They have a new onset of severe agitation. So remember, acute first before chronic. Letter A is hypertension our priority. Letter B, chronic insomnia from the term itself, chronic. So what do we prioritize? Acute first before chronic. So letter B is already at. out of the system. Letter C, severe agitation and pressured speech. As we know, severe agitation can mean a lot of things. Agitation could mean they are what? Breathless, agitation, tachycardia, tachypnea are the initial signs that the patient may be experiencing low oxygen in the brain and could mean certain things like hypoxia. And then letter D stands for weight gain. Okay, a lot of you answered letter C. John, Rosalind, how about the rest? Janet, thank you for participating. Tiffany, great job, everyone. So based from the option, treat the acute before the chronic. Let's rebuild the rational. Very good. So anybody with severe agitation or pressured speech is our priority. We need to investigate further what is going on because what's going to happen, it's a worsening condition. They could have an impaired judgment and they may need hospitalization. Okay? So acute psychiatric destabilization takes priority over chronic or stable conditions. The other options can wait out. But letter C, if they have severe agitation and pressured speech, we need to rule out what's causing that. There's probably oxygenation issues, and at the same time, there could be in a medication that could lead to what toxicity, or even if they taken like illicit substances. So these are things that we need to rule out. Remember, you can treat stable patients in your outpatient practice, but if it goes out of hand, we need to refer them out, and that's important. Okay. Very good. Let's go to question number 4. Love this. So another test-taking strategy is know your first-line treatments. And I could not further emphasize to all of you guys that are testing, actively practicing, or if you are new to the psych NP role, the first line of medication is important. And letter I is indicated therapy. Letter R, know your risk factors, right? Know their social history, know their familial history, their growth and development, very important, and know their trauma. Remember, a lot of our patients could be underdiagnosed that they have unreported PTSD in the past, wherein they either got sexual abuse or got into a drastic or an event that causes their nervous system response to react in a negative way. And then letter S, side effects, very important. A lot of your patients will stop taking their medications because they don't like the side effects of the medications. But if they are informed and if they understand the risks versus the benefits, then they have a better understanding of the medication, the more compliant your patient's going to be. And then T stands for time to response. So use this when you are asked about the best treatment. For example, for depression, right? As we know, it's an FDA approval and also based from our guidelines, SSRIs remains to be the mainstay treatment and SNRI and plus therapy. So before you prescribe different medications like your monoamine oxidase inhibitors, tricyclic antidepressants, choose a medication that has the least side effects and they have a better outcomes for our patient. And compliance, a lot of your patient should be screened for sodium level if they are on SSRIs, particularly the elderly. Now we also PTSD. Remember this EMDR, which is trauma focused therapy, and you could be starting them with SSRIs too and SNRIs. And somebody with ADHD, remember stimulants unless contraindicated. And then particularly patient with bipolar depression, avoid antidepressant monotherapy because what's going to happen? Mania. Okay, let's look at the question. A 35-year-old patient with PTSD reports nightmares, hypervigilance, avoidance behaviors, and intrusive memories following a traumatic event 8 months ago. So you really need to make sure that you're highlighting or knowing your 8 months ago as part of your timeline. Which treatment is considered the first line? Letter A, remember long-term benzodiazepine therapy. As we all know, benzodiazepines should be what? Short-term treatment only. So I think letter A is X. Letter B, trauma-focused psychotherapy with or without an SSRI or SNRI. Or letter C, haloperidol monotherapy. Or letter D, do we go with lithium, right? And there could be questions about, managing nightmares for your patient, right? So if we're looking at nightmares for your patient, we need to treat them with prazosin, minipress, and also that's very important. So just think about PTSD, prazosin for terrible, scary dreams. Once again, PTSD. We give prazosin for terrible, scary dreams. So you could start from 1 milligram, 2 milligram, 3 milligram, 4 milligram, 5 milligram, 6 milligram. Start low, then go up slow. All right, a lot of you have answered letter B. Thank you for all those who are tuning in. And if you're new to our program, once again, please tag your friend, your best friend at Psych NP School, or your Psych NP preceptor who are tuning in right now. It's very important. And let's help them pass the board. All right, let's rebuild the answer. It's not letter A, not letter C, and not letter D. As we know, trauma, right? Trauma-focused psychotherapy will be a priority. So that will be your EMDR, okay? Eye movement desensitization response therapy. And we're looking at trauma-focused psychotherapy as the first line of treatment. Remember, always know your first, right? Evidence-based practice guidelines before considering the second line of options. Uh, Once you guys start practicing, though, each patient may be different from each other. So we don't mirror our treatment plan, but we treat the patient holistically and we treat them with an individualized approach. So it's always important not to copy the treatment plan of each patient, but see them as a whole. But when you're testing for the board exam, it's always by the book. Remember, there are a lot of ways that we can treat PTSD, but always follow your book and guidelines, evidence-based practice. Okay, next slide. Okay, what's for red flag medications? Okay, so what are those red flag medications that we're looking for? And I think Professor Letty emphasized this yesterday too. We're looking at lithium toxicity. Remember those tremors, seizures, you have nausea, vomiting, diarrhea that will signify early signs that the patient is undergoing lithium toxicity. So we really need to be vigilant and we really need to make sure that we're checking that before adjusting and also looking at the medication of the patient at all times, especially in summer, that they're prone for toxicity. Agranulocytosis with clozapine, we talked about that last night. And your monoamine oxidase inhibitors, I remember this like Panama. Your monoamine oxidase inhibitors are Panama, Parnate, Nordil, Marplan. So remember, no tyramine-rich foods because they can cause hypertensive crisis. And then your benzodiazepine, especially for elderly, they're prone for falling. And then you have your serotonin syndrome. Remember your treatment plan for your serotonin and your neuroleptic malignant syndrome. Serotonin syndrome, we give periactin. And your neuroleptic malignant syndrome, we give your Danbro, dantrolene, and bromocriptine. And then your Steven-Johnson syndrome for your lamotrigine or lamictal. So think about that. Okay. Once again, know your LAMBS. Let's look at the keywords: fever, rigidity, rash, confusion. They have tremors and diarrhea or abnormal labs like your ANC count. Next slide, please. All right. A patient is taking sertraline and linezolid, presenting with agitation, hyperreflexia, and clonus, and diaphoresis and fever. What is the most likely diagnosis for this patient, or what is the patient experiencing? Letter A, serotonin syndrome. Letter B, neuroleptic malignant syndrome. Letter C, lithium toxicity. Or letter D, acute psychosis. Okay, type in your answer into the chat box. Thank you once again for those who are tuning in from different parts of the states. And also, if you're in the Philippines and you're tuning in, welcome, welcome. Okay, so we have your medication. Sertraline is also known as Zoloft. We are screening for the sodium level of your patient. Remember, your sodium level is 135 to 145. Your linezolid is also known as your Civox. Remember, this medication is a non-selective monoamine oxidase inhibitors. When we look at your linezolid, which could be antibiotic, it can interact with psychiatric medications that can increase your serotonin level. So what will be your answer here? Alpha, beta, Charlie, or delta? Okay. A lot of you have answered. Let's look at this. Letter A. Very good. Let's look at the answer. All right. So serotonin syndrome. We know that in serotonin syndrome, this is easier to treat than your neuroleptic malignant syndrome. So what will be the patient's complaints? They will tell you they have agitation, high body temperature, and also hyperreflexia. Okay, very good. So on the board exam, Pearl, hyperreflexia plus clonus, always think about your serotonin. So remember, your muscle tonicity is highly important. So even they have hyperreflexia, right? We test that with your deep tendon reflex, and then also your fever, which is high body temperature. So they could either shiver. So our priority is to give the medication for patient cooling measures, but always stop the offending agent. So what is the offending agent in the question? We stop your linezolid and your sertraline, and then we give the patient some cooling measures. They're usually treated in the ICU for a couple of days, 2 weeks, and this is easier to treat than your NMS. So we give periactin once again, which is the medication of choice for your serotonin syndrome. Okay, next slide, please. All right, now therapeutic communication always wins. So our mnemonics will be valid. So V stands for validate their feelings. So if the patient is telling you, oh, I'm so sad today, I'm so depressed, we always need to consider their feelings. Validate their feelings means exploring them. It seems like you're sad today. It seems like you're feeling a little bit down today. So that's very important when we look at open-ended questions, and validating their feelings is very important for your board exam, because if we ignore it, it's red flag. It's an incorrect option. Asking open-ended questions is always important. So I always practice this in my clinic. How can I best help you today? Like, how can we best address your care today? So that's very important. When we ask open-ended questions, the patient will verbalize more of their needs and more of their problems. The only time we ask close-ended questions is if they're suicidal, or if you want to focus on a certain question. Like, for example, right, you need to ask them if they're going to commit suicide. Like, are you thinking of harming yourself, and in what way? Then that's the time we're in. We can ask close-ended questions. Or if you're screening for abuse, right? And also screening for a perpetuator. Oh, listen without judgment. This is very important. A lot of our patients that we see in our day to day, they always want to be validated, seen, and heard, and that's important. If we have an open communication with our patient, if we have a therapeutic alliance, every job that we do is so much easier. Okay. Now, we'll also look at your letter I, investigate safety. Do not go into the patient's room alone if they have history of aggression. You always need to be near the door, and then there should also be a staff that can see you, or at least be with someone that could help you out manage the patient well. Because if they have aggression history, do not go to the room alone, or else you're gonna end up being dead. They can either strangulate you or hurt you. So please always make sure institute your safety. And we've heard a lot of stories like nurse practitioner, a CNA, LVN, RN, or even a family member got killed in the hospital, or there's so much violence. So I always need to emphasize safety in the hospital as a priority, not only of the patients but also the staff. And for all those administrators, please let's let's always prioritize the safety of our staff. Okay, we are the backbone of healthcare, and we need it to be feel safe too when we're working. Letter D, do not give false reassurance. So what is example of that? Oh, everything's gonna be okay. You are fine. You are treated here in this hospital. This is the best hospital that you're ever gonna be. So that's like giving false reassurance or telling them, oh, tomorrow you'll be better. Oh, tomorrow is a better day. You'll be fine. Okay. Especially when they're grieving, allow them to grieve. So also giving false reassurance will create a barrier between you and the patient. So what will happen? Therapeutic rupture instead of alliance. Okay. So do not say, don't worry, everything's gonna be fine. Changing the subject, minimizing arguing with the patient is also non-therapeutic. Remember, valid. Let's apply it in a question. So a patient newly diagnosed with schizophrenia says, the voices are telling me that the staff is trying to poison me. Which response is most therapeutic? So your keywords there is most therapeutic. And also another keyword is schizophrenia. And the patient is experiencing like what? Auditory hallucinations. They're hearing voices. So some of you may have seen A Beautiful Mind by Russell Crowe, who won the Emmy Awards too, right? So you need to make sure you guys know that that specific patient has like a paranoid schizophrenia. John Nash. He was a Harvard instructor too. Very good movie. So letter A, the voices are not real. Do you tell that to your patient? Letter B, nobody is trying to poison you. Letter C, I understand that the voices seem real to you. What are the voices saying right now? Letter D, you need to ignore the voices. Okay, remember, we've heard so much in the bedside, or we heard so much from our colleagues sometimes that are non-therapeutic response. You're taking the board examination, you're doing your job to be the most therapeutic psych nurse practitioner. And letter A, the voices are not real. That is incorrect. Letter B, nobody's trying to poison you. Are you trying to argue with the patient? Remember, be therapeutic. Letter D, you need to ignore the voices, then that's being non-therapeutic too. So you're not addressing the real concern of the patient. So letter C is the answer. Very good. That's your Charlie. I understand that the voices seem real to you. What are the voices saying to you right now? This involves exploration. What else? It's giving you an opportunity for the patient to talk about the voices, and it's showing an authentic feeling that you care about the patient, that you're hearing voices and you're validating that. And the patient will feel if you're authentic with them or not. And that makes you um, develop your skill set as a psych nurse practitioner. So it really takes a lot of effort in eliciting these skills, and it's learned over time. So don't be hard on yourself. If you're not comfortable, the more you practice, the better you're gonna be. Great job, everyone. I think we're gonna be seeing a lot of psych nurse practitioner board certified next week. Next slide. And then diagnosis depends on time plus the impairment. So we're looking at the timeline. That's very important in your DSM-5 diagnosis, right? There are 6 months, 3 months, 12 months. So there's like different timeline that we need to remember, like 2 blue weeks, depression, major depressive disorder. 2 blue years will be your dysthymia or dysthymic disorder. So you really need to make sure you know the timeline, you know what the impairment is and the pattern of symptoms, and what the substance or medical diagnosis of your patient. Remember, we're not just treating them in one aspect. The body, the mind, and the soul is a good parameter for you guys to look at because they're interrelated. If I have COPD and I have anxiety, and you're not treating my anxiety well, I'm not going to go to the clinic because I'm anxious to see a doctor. Then now I'm not going to take my puff and medications or even like be compliant to you. If I have hypertension and I'm depressed or I'm diabetic, I'm not going to check my blood sugar at all because what? I'm depressed. So look at all of those DSM-5 criteria that we're missing in outpatient practice. So a lot of this are commonly missed in outpatient practice that we really need to put an effort as a primary care provider to bridge the gap between the patient's symptoms. Right, let's look at the next question. So you have a 68-year-old patient developing visual hallucinations. So they're saying things, part of your positive symptoms, and paranoia over 48 hours after being treated for pneumonia. Family reports no psychiatric history. What should the psych NP do first? Tamara from LinkedIn says letter C, diagnose delusional disorder. Letter A stands for diagnosing schizophrenia. Is that our first thing? First thing first. Letter B, start long-term antipsychotic treatment. Letter C, diagnosing delusional disorder right away. Letter D, rule out delirium and medical causes. So once again, this is a 68-year-old with no psychiatric history. They're seeing things. Visual hallucination could mean a classical symptoms also of your Lewy body dementia, right? Remember, if they're seeing things, that's a characteristic of your Lewy body dementia. So remember VH. Visual hallucination is your Lewy body dementia. So remember test taking strategy, letter A and letter C. Two options that are the same, diagnosing. They are similar. It may not be the best answer. But if we look at letter B, starting a long-term antipsychotic treatment, right? That's very invasive right away. We need to make sure we rule out what is going on with the patient. So let's rebuild the answer. Thank you for all your answers. Really appreciate it. So rule it out first, right? Red flag symptoms, they're elderly. It's an acute onset, medical illness, no psychiatric history. Think about delirium before psychiatric illness. And if it's not delirium, it may mean that they may have a Lewy body dementia or something else that we really need to rule out. So once again, before you treat, before you diagnose, the you assess first, and that's very important. Okay? So run some labs before treating the patient. Next, test strategy. Great job. Legal and ethical questions. We always follow the duty. So our mnemonics is care. So I care about you passing the board exam. So please make sure, don't forget about care. Letter C stands for confidentiality. Letter A stands for autonomy, right? So autonomy is the right for your patients to decide on their own. Letter R, reporting duties, and letter E stands for emergency exceptions. So there will be cases wherein the patient will tell you, I'm going to kill my roommate tonight. Please, let's keep this a secret between you and me. So remember, you tell your patient, and you cannot respect confidentiality if there's a presence of threat to safety, and if it's a safety that your patient's gonna kill somebody or is about to hurt somebody and having homicidal thoughts and they have an active plan and they tell you we are mandated by law to report it and make sure the legal duty to report. As a nurse and as a nurse practitioner, as a healthcare worker, we need to call police if they're out of the office or if they're in the hospital. Then we really need to make sure we tell our patient, I could not keep that as a secret, I'm sorry, right? All right, let's apply it in the question. A competent adult patient tells the PsycNP, I used cocaine last weekend, but I don't want anyone to know. The patient denies suicidal thoughts and homicidal thoughts, abuse, neglect, or safety concerns. What should the PMHNP do? Letter A, do we notify the law enforcement? Letter B, do we inform the patient's employer? Letter C, do we maintain confidentiality? Or letter D, do we contact the patient's family? Type in your answer into the chat box. Very important. Once again, thank you for all those who are tuning in to LinkedIn, YouTube, Facebook, Instagram, TikTok. And if you have a friend that is testing next week, 2 weeks, 3 weeks, 4 weeks, 3 months, 6 months, a year, we're here for you. And that's pretty much important for you. Okay? So type in your answer into the chat box. Alpha, Beta, Charlie, or Delta. Okay? All right. Thank you once again, John from Baltimore, NJ Ross, Heidi from California, Cruz UD, where you from? Janet, where you from? All right. So thank you, Clementina, for answering. Nancy Botwin from Facebook. Thank you. All right, let's reveal the answer. Remember the song I'm in Love with the Coco, right? I used cocaine last weekend, but I don't want anyone to know. We still maintain confidentiality. Substance use alone does not automatically require disclosure when there is no legal reporting requirement or immediate danger. So once again, we always respect Health Insurance Portability Accountability Act. So remember, all the electronic health records are um, are held in highest confidence, and make sure we don't bring home any documents to us about a patient's information. They tell you one of your patient is a celebrity and they're confined in your hospital, then always make sure that we don't have the right to access their chart if you don't have a direct responsibility to view the chart of the patient. So remember, always practice confidentiality in the exception that there's suicidal, homicidal, or there's a legal court order that we can supersede privacy over safety. So remember that, okay? Next question. And another technique. Wow, we're almost done. Child questions, we always focus on developmental thinking. Your mnemonic is age appropriate behavior. Remember, 3 months they have a head control. So this is 3 months. Trunk control is 6 months. And then 9 months they have a leg control. So remember, 3, 6, 9. The same thing as the song says head, shoulders, knees and toes. 3 months, 6 months, and 9 months. 3, 6, 9. So you don't forget about that, okay? So if they have an age-appropriate questions, use the patient parameters in terms of their growth and development, and also environment, safety, school trauma. Most common questions is, oh, Chris Yuri is from Iowa. Hello from Iowa. Wait, I've been there. I think I went to North Iowa Community College before. Yeah, during December, the weather is kind of not nice at that time. Okay. So do not diagnose too quickly without considering normal parameters, trauma, and very important for you guys to remember for your board exam is look at the past formula. Okay. If we're looking at the patient who is a pediatric patient, we always screen for the growth and development. We screen also for history. Like if they have a sleep disorder, right? You always want to ask, does your mom or dad has any history of sleep pattern issues or sleep disorders like insomnia? Or if they have nightmares, panic attacks, always screen for family history. Okay. And as for collateral information, if they have ADHD, we're looking at Vanderbilt. We're looking at also TOBA testing. We're looking at other testing that they can do or their self-report ADHD questionnaire. Okay, let's look at the next question. Okay, a teacher reports that a 7-year-old student never sits still. During the assessment, the PsycNP learns the behavior occurs only at school. Academic performance is average. The parents do not observe symptoms at home, and the symptoms began this year after changing teachers. What is the most appropriate next step? Letter A, do we diagnose ADHD right away? Letter B, do we obtain additional collateral information and evaluate environmental factors? Letter C, do we do this? Start stimulant medication right away. Or letter D, do we diagnose the patient with bipolar disorder? Remember, some symptoms of bipolar anxiety could overlap symptoms of ADHD too. But it's our role as PsycNP to always make sure we gather the pertinent information before arriving at the best answer for your exam. So 2-to-1 ruling. Remember, take out two options that are similar. When they are similar or the same in context, they may not be the best answer. Thank you, Larshanda, for responding. Clementina, Anuli, Rosaline, Heidi, Jenny, okay, Larhanda. And for all those who are tuning in live once again, this is Pastor Center. Don't forget to like, subscribe, tag your friend. We have some deals going on, 10% right now during Father's Day weekend too. Make sure to follow us, like us, tag your friend, LinkedIn, If you're actively practicing due to the program, planning to enter PsycNP, welcome. If you're a psych nurse right now, welcome. Thank you for what you do to our community. And you guys are the best healthcare professionals. Okay, let's look at letter answer. We gotta obtain additional collateral information. Remember, evaluate the environmental factors of your patient before we rule out ADHD. Remember, as we know per DSM-5, right? Certain criteria like you have your hyperactivity, inattention, combined type. So we need to make sure also we're ruling out ADHD, something to do with your prefrontal cortex and something to do with your neurotransmitters. So there could be different overlapping information that we really need to rule out before diagnosing somebody, right? So ADHD onset before age 12 as per DSM-5 guidelines. So we need to rule out, did they ever struggle in school? How are they in at home, right? Are they able to function effectively, right? Are they not able to sit still? Are they following directions? And then we need to make sure we do those screening tests that we as much as we can for our patient before treating them with stimulants, right? So we should be on the safe side as clinician and validate the symptoms before giving that. So if a patient has bipolar disorder and now you're giving them the stimulants, they gonna end up being manic or they have mania. So be careful with that. So there are different medications out in the market, right? That we could treat ADHD for stimulants and non-stimulants. Next question, please. So do not overthink the question. I think the most common pitfalls for testing, it can be on the NCLEX, FNP, PsycNP, AGNP, acute care Gero NP, or any examinations is we're overthinking. We're jumping one step ahead of the game, or we're always asking what if? What if the patient is alone in the unit? What if there's no staff? What if there's no medication? What if? Remove your what if. Read the stomach carefully. Eliminate unsafe answers. We're looking at giving medications abruptly without assessing the patient. Answer what is being asked and also do not add facts that are not there. So what do we mean by that? You are adding your own scenario to the question, which is not safe for your patient. So always choose safety, most evidence-based practice, least invasive, simple to complex, and patient centered. So before you treat the machine, treat the patient first. Before you check the machine, treat the patient first. All the time, patient centered care is a priority. Wherever you go and which exam you're taking, the patient comes first. Right, let's look at the next question. So a patient says, I've been feeling down lately. What should the PMHNP do first? So for this session, I'm teaching you guys how to strategize effectively and how to look at the keywords and how to look at what potential answers you have in mind. Letter A, do we diagnose right away with major depressive disorder or MDD? Do we start an antidepressant? Do we further assess mood symptoms and functioning? Or do we recommend hospitalization? Remember, it takes a lot of test taking strategy. If you've taken different form of examination, it's all about a habit of understanding the question, applying your test taking strategies, and believing in yourself, trusting the process. Okay. All right. Please type in your answers. So we have Markia, Sean, Clementina, Cruz, Jenny answered, Larshanda, Shanta. Can you type in which state are you guys from? And please make sure to tag your psych nurse practitioner best friends that are out there listening in from the East Coast, West Coast, and from the different states of United States. We are here to help you out pass your board exam once again. All right, let's reveal the answer. You got it? Make sure you further assess the mood symptoms and functioning. So the stamp provides insufficient information for a diagnosis. Remember, when the assessment is incomplete, we always do further assessment. So do not add facts. Remember, you are not the one telling the story. The question is giving you the scenario, and if there's lack of information, then um we further explore on it. Wow, somebody from Kansas, welcome, and somebody from LA. Clementina, we will have in-person review soon in LA. We're gonna post that details and information. We did we did it last year during the Pride Month, so watch out. And Lashonda from Arkansas, thank you and welcome. Oh my God, thank you so much. And we have Dr. Karen from IG from Queens, New York. Thank you so much for tuning in. So further assessment is required. Oh, Shasta from Missouri, thank you. Once again, if you have your classmates that is struggling for their test taking, they could not, study smart, and they could not, they cannot find the time to study. We have a great program for you guys, and it's pass guarantee. So we want to make sure we want to walk you through and give you those mnemonics. All right, that's once again, I'm inviting you guys once again to like, subscribe, follow, and also tune in to our next classes. So safe psych and peace. Make sure you guys are practicing safety. Safety first. Letter A, assess medical substance causes. Know your letter F, first line treatment. Know your emergency before the routine. And as a psych NP, we prioritize acute problems before chronic. We look at medication red flags for the patient. We want to approach them humanistically in terms of therapeutic communication. Never ignore legal or ethical responsibilities. And also, pediatric development questions is also important. So we're looking at PAJ. We're also looking at your Eric Erickson questions. Read the question, eliminate unsafe options, answer only what is asked, do not overthink, and every time, always the patient comes first. The board rule is always choose the safest, most evidence based practice, least invasive, and also patient centered care. Once again, I'm Pedro Morante. I have a special package for you guys. And one thing for and foremost, please buy this book, Rise with Pass, if you're testing really, really soon. It contains all the mnemonics that we've been telling you, and also it has a notes here, and also has practice questions. So what I tell my students is that you can utilize this with your clinical practice approach questions too. And then the master feel, which is also almost sold out. So we bundle this together. Um, It comes with mnemonics from domain 1 to 5 and very easy to read. And at the back, I'm giving you the diagnosis and medication safety protocol. So some of your antidepressants, antipsychotics, mood stabilizers, and breaking down, and SUD medications, very important. And dementia medications. So a lot of good things for you guys to approach your examination. But the most sold out book right now is our PMHNP Mastery. So I'm sorry for those who ordered the physical copy. It may take a little bit because our book that is physical copy is sold out, but we have ebook available for you for purchase. And once you buy the physical book as a complimentary, we're giving you also an ebook access. And also, it's 10% right now. It's Father's Day weekend, and we're promoting that for you guys. So if you want to get a high yield content, what else? Board focus strategies, practice questions, clinical pearls, you can use this while you're in practice, while you're a student, you're doing your preceptorship, and also after opening up your practice. A lot of psych NPs right now have their own private practice. So you guys can utilize that 400 pages of psychopharmacology content areas. It comes with the uh, the guidelines, what else, what to look for, labs to monitor for, and of course, the safety dosing for your patient. And it's 10% right now. So thank you for those who have bought it. And if you have bought them today, it should arrive within next week since we already ordered the physical book. But please do not forget, Professor Ledy and I we're collaborating for the PMHNP one day last minute prep. We have limited spots Okay, this is first come, first serve, walk in, walk out, exam ready. The QR code is there. Just type welcome 10 for 10%. So it's 8 a.m. till 2 p.m. So one day for a lifetime. What is one day for a lifetime? Join our class and prepare to pass. So once you pass, doors will open. Gonna help you open your own private practice, set up your own corporation, and make sure to do a lifetime mentorship with us and be part of the community that supports the psych nurse practitioner. So once again, I'm Pedro E. Morante. My vision and mission is just to offer you the most simple study tools that you can use for your practice while you're a student, and then also creating a mental health impact to the community. The more psych nurse practitioners, the better for our community, especially right now. And also, we have BLS, ACLS, Pulse, CEU available in our website. We are under the process of some accrediting agency that will give you an advantage of being an ANCC um, CEU hours. So it's upcoming. We're crossing our fingers that approval will push through. So that's another update from past review. So please pray for that it will happen, and please leave a comment and feedback if you are wanting any contents that you want us to do live on. But see you guys tomorrow 6:30 p.m. once again. I Once again, bye bye. Thank you, East Coast, West Coast, Hawaii, Philippines, and all over the world. Thank you for choosing Pastor B Center. Appreciate it, all of you. Bye bye.